Hi everyone. So आज के टॉपिक में we are going to discuss about the radial nerve, as you guys can already tell. So it is a confusing topic. जो majority even the at the PG level, it is sometimes confusing to get the codes, the supply, the actions, and often it gets confusing definitely for the MBBS graduates as well. So I'll try to simplify this topic as much as I can, and let's start. So radial nerve. Radial nerve arises from the posterior cord of the brachial plexus. So this is our brachial plexus. यहाँ पर it arises from the posterior cord. Okay. So it's the terminal branch of the posterior cord of the brachial plexus. So the root value will be C5, C6, C7, C8 as well as T1. Okay. So it ultimately, where does it supply? We are talking about the sensory supply here, mind you. So we'll discuss it further also, but it supplies the dorsoradial aspect of our hand. So the radial nerve, the superficial radial nerve in particular, supplies the dorsoradial aspect of the hand. Okay, so now we're going to discuss about the course and everything, which is the most confusing topic in the radial nerve and often the most commonly asked one as well. So in here, it first supplies the long head of the triceps before it enters the spiral groove. Okay, and once it passes through the spiral groove, it supplies the lateral and the medial head as well as the inconius muscles. Okay, so all these get supplied as it descends down. So after it passes through the spiral groove, it descends on the lateral aspect and pierces the lateral intramuscular septum. Once it pierces the lateral intramuscular septum, it supplies the brachioradialis as well as the extensor carpi radialis longus, that is the ECRL muscle. Okay. Further, it descends down towards the forearm and gets divided into two branches, one superficial sensory and one deep motor. So this deep motor branch, it goes through the deep motor branch, which ultimately passes through the supinator muscle, and it is also called the PIN, that is the posterior interosseous nerve. Okay, mind you, it doesn't have any sensory component, so the PIN branch is completely motor branch. So now talking about the superficial radial nerve, it descends along the belly of brachioradialis muscle and it supplies what? Dorso-radial aspect of hand plus the thumb. So dorso-radial 3.5 fingers. That is the sensory supply of the superficial radial nerve. Okay. So moving back to the part of the PIN, it supplies the extensor as well as the supinator muscle. So in extensors, we have wrist extensors, thumb extensors, finger extensors. Wrist extensors, we have extensor carpi radialis brevis, extensor carpi ulnaris. For the thumb, we have the EPL or the extensor pollicis longus, abductor pollicis longus, extensor pollicis brevis. For the fingers part, we have the extensor digitorum communis, extensor indicis, and extensor digita minimi for the little finger. Okay, so this is more or less about the course. In the sensory part, this is the thing so it is supplied, sensory part is supplied by the posterior cutaneous nerve of arm, and similarly posterior cutaneous nerve of the forearm. Okay, so these are the sensory component of the radial nerve. So in this diagram also, if you can look closely, we have the radial nerve that is descending from the posterior cord of the brachial plexus. So this is the radial nerve. It descends along the posterior cord of brachial plexus, supplies the long head of the triceps before entering the spiral groove. After it enters the spiral groove, it supplies three muscles, the lateral and the medial head of the triceps, as well as the inconius, after which it pierces the lateral intermuscular septum around here and descends to supply the brachioradialis as well as the extensor carpi radialis longus or ECRL. Further, it divides into two. This is the deep branch going, and this is the superficial branch. So we see the superficial branch descending along the belly of brachioradialis to ultimately supply the dorsoradial aspect of the hand, whereas the motor part, that is the deep part without any sensory component, is called the PIN, and it ultimately supplies the supinator through which it's passing, as well as the extensors of the forearm, the wrist, the thumb, the fingers. Okay. So now we are going to discuss about the most important part of this topic, that is the different levels of nerve palsy. So the first one is the very high. So once we have the compression at the level of axilla or at the level of the brachial plexus, the posterior quad region or something. So everything radial nerve supplies distal to axilla is affected in this condition. Okay, so we have the blockade here, so everything distal to it gets disrupted. So the most common example is crutch palsy, shoulder dislocation or any traction injury, any brachial plexus injury due to road traffic accident या penetrating trauma. So the motor findings will be, अगर कोई भी हमारी supply नहीं है distal to the posterior cord part, तो all our muscles that are being supplied by the radial nerve get affected. Triceps, inconius, brachioradialis, ECRL, ECRB, ECU, finger extensors, thumb extensors all get affected. Similarly, sensory component में ये सारे भी all get affected. Okay, so this is an example of how a crutch, so ultimately if due to the improper sizing the wrong way of usage of the crutches, the patient can get compression of the radial nerve around here and ultimately से crutch palsy हो सकती है. So this is one of our patients which we had in our OPD. So as you can see, his acromion was very prominent. He had a history of road traffic accident about 15 years ago. So where he sustained injury towards his axilla and his brachial plexus injury ultimately it was. And you can see यहाँ पर his arm was totally wasted, no muscle. He had this thing which is called the pseudo subluxation of shoulder, basically because of the deltoid paralysis. Okay. So now we're going to discuss about the high radial nerve injury. The most common site is the spiral groove of the humerus, and the most common example are the shaft of humerus fractures, as well as any iatrogenic or surgical injury caused at the time of distal humerus fracture fixation, nerve exploration, or even traumatic. Okay. So the most common example for the shaft of humerus fractures is the Holstein-Lewis fractures, that is the distal 1/3 of the humerus fractures. So in this case, the triceps and brachioradialis may be spared. So if they are spared, we will have elbow extension. But about ECRL, it's kind of plus minus. हो भी सकता है या नहीं भी हो सकता है depending on the site of location, site of lesion. So motor component में what will we see? Since हमारे wrist extensors की supply नहीं है, we get a wrist drop, we get a finger drop, we get a loss of thumb extension. In sensory, यहाँ पर हमारी वही posterior forearm, dorsoradial hand या फिर first dorsal web space. Although the sensory distribution of this lesion can be variable, again depending upon the site. So the classic example is Saturday night palsy. पूरी रात पार्टी करी, सुबह wrist extend नहीं हो रहा, so that can be Saturday night palsy. Compression of the radial nerve, Holstein-Lewis fractures, that is the distal 1/3 of the humeral shaft fractures. इस फोटो में we can see the surgeon trying to isolate the radial nerve. So एक wire loop से below the plate the radial nerve is explored. This is one of our cases where we had a anomalous variation of the radial nerve. So if you look closely, यहाँ पर we can see it actually had multiple branches, but in this picture only two major branches of the radial nerve are visible. Although इस level पे कोई divide नहीं होती है, but we sometimes get these anomalous variations of radial nerve. Now we have the low radial nerve palsy. Here the nerve has already supplied the triceps, the brachioradialis, the ECRL part. So lesion is around the distal arm, before or around its division into superficial or deep branch. Okay. And so for pen palsy, firstly, since it's a completely motor branch, sensations will be completely normal. In case of the wrist extensors, क्योंकि already पहले supply हो चुकी है ऊपर for the brachioradialis and the ECRL, so wrist extension is there. But हमारी finger and thumb extension is gone. Okay. अगर हमारी सुपरफिशियल रेडियल नर्व में कंप्रेशन है या फिर कोई इंजरी है तो हमारा सिर्फ सेंसरी कंपोनेंट इज गेटिंग डिस्टर्ब. सो वी हैव अ नॉर्मल मोटर फंक्शन, वी हैव अ डॉर्सोरेडियल सेंसरी सिम्टम्स. दिस इज कॉल्ड सुपरफिशियल रेडियल न्यूरोपैथी और द वॉटनबर्ग सिंड्रोम. ओके, सो दिस इज अ क्विक टेबल. यहाँ पर वी कैन सी इफ द लीजन इज वेरी हाई, ट्राइसेप्स में नहीं है, so each and every muscle gets affected as well as the sensations part get affected. If it's a high lesion, we still have the supply to triceps or brachioradialis की होती है. Wrist extensors, finger extensors, thumb extensors gets affected. For the low radial part, again triceps and brachioradialis की है, wrist extensors का plus minus है, finger and thumb extensor are affected. For the PIN, sensations normal है since it's solely a motor branch. Triceps, brachioradialis, wrist extension, all are normal. However, finger and thumb extension are affected. For the superficial part, motor component is totally okay, but sensations are affected on the dorsoradial aspect. Again, it's called the Wartenberg syndrome. So that's pretty much it for the radial nerve part. Hope to see you guys next time.